good to get started. Everybody else will just log in, I guess, on their own time. So for everybody joining in now, I'll introduce myself. You've probably seen my name through all the correspondence. My name's Jyoti. I work for Utiva Health. Well, the brand's Utiva, company is Zio Plus. And I'm going to do a quick housekeeping, just go through housekeeping really quick before I introduce Dr. Imlah and Dr. Pratt. So for today's agenda, we are set to run officially till about 8:30. So we'll have our presentation, Q&A to follow. Be sure to add all of your questions throughout the presentation in the chat or the Q&A box. It's up to you. We'll be making a note of them, and then at the end of the presentation, Drs. Imlah and Pratt will do their best to get through as many as possible. Following the Q&A, we have a little raffle for the Amazon gift card. So you'll have to stay on for that, because if we call your name, you're going to need to say I'm here and claim it. And then after that, after the raffle, anybody who wants to hang on for any product information related to Utiva, if you have any questions, myself and Mary, who's a part of the team, will be here for like a little product presentation. Okay. So with that, I would like to introduce Dr. Imlah and Dr. Pratt. Thank you so much for being here with us this evening. We have a lot of interest in this talk. We're really excited to hear your perspectives and what you have to share.
Thanks, Jyoti. Hi, everybody. Thanks for coming and joining us tonight. I'm Shona Imlah. I'm a family physician in Canada. I work in a functional medicine private practice several days a week. And as well, I work in labor and delivery. I have a history of working in very isolated private practice, and as well as working in the system in urgent cares. But for the last few years, it's been primarily labor and delivery and functional medicine.
I'm Emily Pratt. Nice to meet everyone. Apologies if we have a screen with Jody going that way, but we'll try to address you. I'm a naturopathic doctor in Kelowna, BC. I've always practiced within British Columbia. For those that are outside of British Columbia, as NDs in BC, have the largest scope of practice of any healthcare practitioner within Canada. I always joke that we have colleagues that do energetic work, but also there's within our scope is primary care. So I've done a lot of functional integrative medicine, but also part of my practice is with primary care, hence the talk about UTIs.
And we should say that Dr. Pratt and I have worked together for about the last 15 years off and on. So we actually work in the same clinic together. So first of all, this is based on our clinical experience and obviously how we apply that within our practice. You obviously need to make those choices for antibiotics and other treatments based on your local prevalence and resistance patterns.
Oh, also with that, sorry, Shona, but
Okay.
Also the disclosures. Can I go back? Also the disclosures, as we have American colleagues joining us, some of this is addressed by what's called our publicly funded system. So we have our universal healthcare within Canada. And so Dr. Imlah is going to speak more to what is standard primary care within our publicly funded system. And I'm speaking more to what I do, which is part of primary care, evidence-based medicine, but also what's involved within the naturopathic scope of practice. And also we spoke about in our chat with Jody before we started, regarding just the prevalence and resistance of the microbes of your area. So we're presenting about antibiotics that are from our area within Canada in British Columbia, but also this presentation is meant to give information, but still use your clinical judgment for your area.
So just a conflict of interest for everybody. We are receiving an honorarium for this talk tonight. So the goals are to just for everybody to gain an evidence-based approach to treating UTIs with standard of care protocols and learn how to integrate those non-pharmaceutical options into your practice. You may already be doing that and we can add something else, or you may be using some of the non-traditional, non-pharmaceutical and you want to know how to integrate some of the pharmaceuticals.
And I also put here as a note that more so for myself, I might interchange naturopathic, integrative, functional, medicine, but essentially we're all talking about anything outside of the conventional standard of care of looking at the functionality and also with being proactive.
So why even talk about UTIs? They're the 12th most common reason why somebody sees their primary care provider. Certainly in Canada, it's the 12th, US might be higher. It accounts for 45% of antibiotic prescriptions in women. So I know in the US, it's over 2 billion in healthcare costs annually, and that's increasing over the last 30 years. And I think everybody that's listening tonight knows that we're trying harder and harder to curb some of the costs. And I think that things that we're presenting tonight will help with that. So we just want to clarify the verbiage we're using so everybody's on the same playing field. So urinary tract infection, also referred to as a UTI, it's an infection that happens anywhere within the urinary system. We categorize it as a lower tract infection or an upper. And this is really important when you're thinking about how you want to prescribe your antibiotics. So a lower is involving the urethra, which is known as urethritis, and the bladder, which is known as cystitis. If we're talking about an upper tract infection, it's once it has gone into the kidneys, and that's pyelonephritis. So when we categorize like this, we do it because then the symptomology of what a patient presents to you with allows you to just slide into one or the other. Lower UTI, frequency, urgency, and dysuria. Pain in the lower abdomen, fever, chills, flank pain, and CVA or costovertebral angle tenderness are all going to move more into upper tract infection. Almost everybody who's going to present to you is going to have one of these complaints, except for one patient, because there's always one who falls outside, and that is asymptomatic bacteriuria of pregnancy. Very special case, no symptoms, and everybody who is pregnant is tested for this in early pregnancy. So we can just kind of set that one aside. We all know it's there. Cystitis, or the symptoms around simple lower tract infection, is going to be the urgency, frequency, and dysuria. It's the most common presentation. Typically, if you see fever, chills, CVA tenderness, and flank pain, now you're talking about an upper UTI. So really important to keep those separate, especially if you're talking to somebody over the phone, or they're presenting at the pharmacy, you don't have a lot of chance to do a physical exam, or you're just not sure, should I go with a big gun for an antibiotic, or shall I just keep it simple? So what's causing it? So UTIs are caused by bacteria. In over 40% of the cases, it's E. coli. We used to think it was just about anatomy. Men had a longer urethra than women did, but that's not only it. So unkeratinized mucosa is linked as one of those factors causing it. So where is unkeratinized mucosa? Well, it's in around the vagina. It is around uncircumcised male. So newborn males have not keratinized their foreskin. So that's where we know that younger neonate males tend to get more infections than males that are more than a month old. And that was part of what had people starting to look at what else is there other than anatomy difference. So one of these theories, and one that will come very much into play later in this talk, is the fact that adhesins and pili on the bacteria increase the virulence factor of the host colonization and enable that bacteria to avoid clearance. So it literally attaches onto the bladder wall. So some of the non-traditional things that we're going to talk about tonight interfere with that attachment. So what drugs are we using? Here, nitrofurantoin, or also known as macrobid in some places, not sure in the US. What's the dose? 100 milligrams by mouth twice a day, slightly shorter for women than for men. It is a first line drug. This is not meant to be for anybody with any symptoms of pyelonephritis. As well, if they have not been given it in the last 6 months. So anybody who you gave macrobid to last time shouldn't get it this time if it's within the last 6 months. Excellent bioavailability in the urinary tract system, rapid relief of symptoms, relatively inexpensive, few downsides to this drug, risky in 3rd trimester, can cause hemolytic anemia in the newborn. It can increase risk in neonates that are at risk for G6PD deficiency. So if their mom has that deficiency, and really can spike their bilirubin. And as well, it's got poor renal penetration. Contraindications. If you have renal function impairment, not a good idea. And again, not for early pyelonephritis. So not for the upper urinary tract infection. Our second drug that we use as our first line is fosfomycin. I think this is a highly underutilized drug. It's simple. It's just a package that you open and mix in cold water. You can drink it. It would be easy to do right at a pharmacy. It's a single dose. It stays in the system for 2 to 4 days. It doesn't need to be adjusted for kidney or liver dysfunction. It's likely safe in pregnancy. It's pretty good in lactation because very little of it makes it to the milk. The only time and where some of the problems have arisen is when people have decided to dose it every second day for 3 doses. It's meant to be a one-time dose. Remember, people will still get symptoms after the single dose. So they tend to think that this is my dose. I'm not getting any more antibiotics. It has to go away with this one dose. It's not true. That one dose lasts for 2 to 4 days in the system. And so having that conversation with them is important. Obviously not meant for early pyelonephritis or if they have a known allergy. Cefixime. This is actually one of my favorite drugs because I do work in labor and delivery and I know it's safe in pregnancy, it's safe in lactation. So really great option. It's also great for that. Well, they say they're having some chills, but they're not 100% sure. And you're like, are they early pyelonephritis or are they just a simple lower UTI? So 400 milligrams by mouth once a day. For females, usually 5 days is enough. For men, 7. It's great for lower and upper. It's excellent for men because when men get UTIs, they tend to be considered complicated. It's great for women and it's actually great for kids. So, and you barely have to adjust it. It's only if for somebody is basically anuric, has a, less than 10 mils per minute for kidney function. It can create an allergic sensitization in kids, but it's pretty rare. And obviously the contraindication is if they have a known allergy. Cipro, which used to be, if anybody that's out there has been practicing a long time, Cipro was always our go-to. Can't remember how many times I just wrote a prescription for Cipro and didn't think twice. Why go with a lesser antibiotic when I can just hit them with the big guns to start? It really should be saved for the upper tract infection. It should be saved for when you do a urinary culture and it isn't sensitive to anything else. It's got excellent penetration. It's inexpensive. And one of the nicest things, it's so easy to switch from IV Cipro over to oral. The tendinopathy, which I'm sure everybody has heard about, it's not as common in the young patient. The people that you have to really watch for the tendinopathy are the 60-year-olds, history of corticosteroid use. So really think about that. If you have an upper UTI and somebody can't take a cephalosporin, this may be your next best option, but just counsel them on the tendinopathy issue. And I don't use it in women who are breastfeeding because of the tooth discoloration. And like all quinolones, you do need to adjust for creatinine clearance.
Okay, so Thank you for that overview. And now part of the presentation is we wanted to give you just a few cases of common UTI patients and how Dr. Imlah would approach it within urgent primary care or within, the conventional family practice versus how a naturopathic doctor, naturopathic physician would also treat it. So the case is a 22-year-old female, chief complaint of pain when I pass my urine. She has increased frequency and some urgency of urination. Has noticed symptoms intermittent for the past couple of days, but the last 24 hours, her dysuria has become much more worse and prompted her to come in. She states she's had some UTIs in the past. It feels like the same thing. Voiding makes symptoms worse. Nothing helps. She tried some cranberry juice and increasing fluids. No fever, chills, nausea, vomiting, back pain, hematuria. So we're thinking more of a lower UTI. She is sexually active in a monogamous relationship, uses condoms. Last menstrual period was a week ago. Normal, doesn't think she could be pregnant, but she's eager to get it treated. So Dr. Imlah, what would you do?
Well, when I look at this case, I say, okay, what are her risk factors? Never met her before. I'm in urgent care. She just shows up. So one, she's using condoms, and are they spermicidal? That increases, so that changes the flora of her periurethral area, which increases the risk of virulent bacteria being able to attach and create a problem. She's sexually active. That also helps. I would always want to rule out whether she was pregnant or not, because I'd be more concerned to maybe move to something like Cefixime. But she has no nausea, vomiting, fever, chills, CVA, tenderness, or flank pain. So my antibiotic choice on her would be, she's a lower UTI, and as long as she hasn't had it before, I would give her the option of fosfomycin or of macrobid. What would you do?
Well, if this was 10 years ago, I would do Cipro because it was so easy. Just remember 500 milligrams, BID, 5/7. And it was more so Cipro was nice from the ID dosing, the twice a day dosing. It's hard when there's nitro or the other ones that are multiple doses. So if she were to present to my office, of course, do physical exam, UA, and likely fosfomycin as well. The conversation I'd also have is around prevention. So a lot of women are recounseled about urinating pre or post coitus. The thing about cranberry juice, everyone comes in saying they've had cranberry juice, and of course they'll get the ocean spray, which has lots of sugar, or there's the pH theory of it. But with a woman that's sexually active, not only just sexual health practices, a lot lately too, I've had conversations around type of intercourse. If people are engaging in anal intercourse, making sure they're having a conversation about finishing with that versus switching between various types of intercourse. But with the fosfomycin, I'd also recommend probiotics. I'm sure also Dr. Imlah would as well. And then also for prevention and reoccurrence, looking at the prothiocidins of a cranberry extract and or a D-mannose.
Okay. Let's try the next one. Pediatric patient, 8-year-old female, chief complaint dysuria for 2 days, increase in that frequency of urination, increased urgency. Parents brought her in because she was waking every 2 hours last night. Parents have given her lots of fluids and cranberry juice and had no change. Denies fever, chill, flank pain, hematuria. Past medical history is healthy, but was on amoxiclav 2 weeks ago for acute otitis media. Her urine dips positive for leukocytes. And what treatment would recommended? Why don't you go first this time?
Okay, well, this is actually, this was one of my cases, a patient of mine. So for this patient, it was positive for leukocytes. The amoxiclav within 2 weeks was a concern. The child was otherwise okay in office. So I did give a prescription actually for nitro for a delayed use. Instead, I dispensed one company that we're not going to mention names of anything. They have a chewable mannose with a cranberry extract. I did that in a probiotic, as well as I gave them a rec for a culture and screen, even though they've had the amoxiclav within 2 weeks to do if needed. But most importantly for this, I counsel patients that, she's otherwise okay. Let's see what we could do with, some of the cranberry extracts. There is data for this, but fill this prescription. And if it's 2 a.m., start giving it to her. And I went, speaking with Dr. Imlah doing this presentation, Cefixime will start being my new go-to, but nitro, the QID dosing, not ideal, especially for kiddos and parents, but even doing this presentation, I'm learning something.
So obviously her risk factor, because she's otherwise healthy, is that she had an antibiotic that changed her periurethral flora 2 weeks prior. There's lots of indirect evidence that this is creating lots of issues, particularly in kids. Even though some of the data is saying don't use probiotics, this is a really great time when we can use probiotics, and typically 2 hours away from your antibiotic use. It will then not affect your antibiotics. It'll just, if you take it too close, it'll kill the probiotics. So, splitting that out. But Cefixime again is one of my go-tos, and that's because it can be divided BID, or it can actually be done once a day. So Cefixime 8 milligrams per kilo per day, divided BID, or just once daily. It's a really good option, and nitrofurantoin is a good option. The problem is that it's QID dosing, and 4 times a day when kids are back in school now, that's a real challenge for people. So I think that the thing that this case is really meant to show you is that we can up front make sure that we don't have this case happen to kids by simply being a little bit proactive in how we're managing the changes in their flora. Also, amoxiclav is one of the most common reasons why people return to urgent care for abdominal pain and diarrhea. So when you're writing a prescription for amoxiclav, totally understand, it's totally needed. It's a great drug, but it's a heavy hitter. And so when you're giving that, just be aware you're going to completely destroy somebody's gut microbiome and setting them up for other infections.
And I know we're going to get the question of, well, if you're giving your probiotics with antibiotics, it's just going to wipe everything out. And there are studies to pull. I'm not going to pull it off my head right now, but typically what I'll tell patients or other physicians that have asked me is that, yes, with something like amoxiclav, we are just having a forest fire burn everything out. But if we space it out, at least for tree planting in between, so then the weeds don't take over. Because for this case, she had amoxiclav, otitis media, and now we're dealing with other subsequent urinary tract infections or other microbiome issues, which of course we're all trying to limit the use of using antibiotics. There's always a time and a place, but there is evidence to support using a probiotic at the time of antibiotics.
And one other little point about this case, if the child is nonverbal, then all of a sudden the parents come in saying they were toilet trained, but they're peeing their pants when they haven't done that for a year. So the child may not be able to explain where their pain is, but that's the classic presentation.
I have a
Okay.
quick question here from the chat. Somebody asked, why not macrobid with the twice a day dosing for this case?
That's a TMS, right?
You can, yeah, macrobid, you can do it twice a day. It'd be a good question to ask the pharmacist in how much volume you're then going to be giving the child. So if you can get that volume down to something that they're going to take and keep down, then that's just fine. But you really have to watch the volume in some of the liquid antibiotics as the child gets bigger. And so this young girl is, I know who she is. She's not a tiny thing. So it's just going to take a bit more because of that.
Got it.
Good question, though.
Mm-hmm. Okay, so our third case, 58-year-old female, last menstrual period 10 plus years ago. She's not sexually active, but comes into the clinic for a chief concern of chronic episodes of increased frequency of urination, increased urgency, mild dysuria, smelly urine, but does not feel like the UTI she's had in her 20s or 30s. She reports vaginal dryness, but normal for her age. She's denying flank pain, suprapubic pain. She has no prescriptions, so typically takes a multivitamin, drinks lots of water, very active with running and hiking. And so what would you do, Dr. Imlah?
So for this, postmenopausal woman, I think the key with her is she's got chronic UTIs. It's as soon as the symptoms are ongoing. So if somebody has repeat UTIs and you've treated them appropriately, then that's when you start considering interstitial cystitis. But the key with this is people come in with increased frequency and urgency, and some of it is truly just around the fact that the vagina is getting drier. Sex is uncomfortable, so they tend to be more uncomfortable if they're riding or hiking or having intercourse. So typically what I'll do is I'll get a culture and I'll treat appropriately. She may well just get macrobid because there's nothing to indicate that she is an upper UTI. But I'd also add an estriol cream into her. I know that's not what the talk is about, but it's a really great option for her. If the urine comes back as negative, nothing grows, then I'm going to start thinking about interstitial cystitis. And then I'm going to really start thinking about adding in a D-mannose and a cranberry in between antibiotics, and then as an ongoing thing, maybe around intercourse or around activity.
Yeah, and from my approach, it would be somewhat similar. That's where kind of a bit of the spoiler alert of this talk is that we do a bit of primary care, but the other aspects. But with regards to this type of woman presenting, culture and screen, because a lot of the UAs for women that are postmenopausal will show positive leukocytes, but they can be asymptomatic. But culture and screen to find out if we need to treat and if there's any potential resistance to the offending microorganism that's causing the symptoms. Another common conversation I have with women is a majority of women of that age have had children. So also about pelvic floor health. So there's sometimes I'll refer to a pelvic floor physio. I found a few women in my practice that they had more of this urgency, but because of the way that their pelvic floor had to be from a hysterectomy or just the changes in the pelvic floor through peri and postmenopause, the position in which their bladder would sit. So they've had to adapt by having different positions to avoid their bladder. And definitely from the changes within estrogen as women go through age that can affect the pH and the microbiome to have propensity to have more E. coli or Klebsiella or whatever the microorganism could be to grow. So in this case, as Dr. Imlah suggested too, in estrogen creams, there's estriol and estradiol. From a preventative aspect and just ongoing symptom management is the cranberry PACs, D-mannose, probiotics, and other lifestyle modifications if they happen to have any triggers associated. So when we start going down the interstitial cystitis pathway, that's where also we take in consideration alcohol intake, caffeine, other sort of food triggers, liquids, but first rule out any source of a chronic UTI.
Okay, do you want to do the next part?
Sure. This was on your slides.
Oh, yeah. So when I used to work in urgent care, when I first started, I would give antibiotics and I'd always write for Florastor as a probiotic. And I always used to get asked why? And by the time I left urgent care, most of the other physicians there were also doing the same thing. And this goes back to our pediatric case in that changes in the periurethral flora promote attachment of pathogenic bacteria. So we get secondary infections because we treat people with antibiotics. So in children, it's often the otitis media or the respiratory. In teens, it's often more common in the spermicide condoms and jelly use. So, getting these people to realize, okay, well, if you're going to be having sex or then make sure you're adding in something to reestablish some of that good periurethral flora, especially if they're not having sex every night and still, when they do use a spermicide condom or jelly. But with children, it's something we really need to think about as primary care is putting them on an antibiotic. I need to add a probiotic.
And then a common thing that I'll get asked is that, well, I'm getting this UTI, but I've been taking acidophilus. So really, I think with probiotics, we're just scratching the surface. And it was a conference I went to a few years ago of like, which probiotic do you choose then? And it's not just an acidophilus. Generally speaking, I'll say human strains. There are some other strains that are plant strains or sourced from other animals, but I always say we're humans, we want human strains. And then the more the better and broad spectrum. So there's always going to be increased gassiness when you start a probiotic, but if we're giving something like, maybe we're not going to give amoxiclav, but if we're using some of the antibiotic treatments, it's not just about vaginal urethra flora, it's also about our small intestine, large intestine, and everything in between. Okay, so the last part of our talk we're doing here are some of the standard naturopathic options when it comes to UTIs. And for the naturopathic doctors on the call, I know there's going to be a lot of questions of why I didn't include all the other various herbs and nutrients and aspects. But I could talk to you for days about that, but the most commonly ones that I've used in practice are the cranberry extracts, D-mannose probiotics. And then at a later date, I'm happy to talk about all the other herbs that have been wonderful in teas and tinctures and whatnot.
Can I add something?
Sure.
These are also the ones for the people who are not naturopathic docs, that these things may be new to you. And these are the ones you can incorporate easily into your practice that are being shown to be highly effective.
Yes, evidence for them. And then also there's a slide further down that I got from the UTIVA presentation about even the acceptance from the SOGC, so the Society of Obstetrics Gynecologists of Canada, believe the urologists, but also when like my colleagues that work within conventional medicine, primary care, having things that are evidence-based and that are starting to be accepted are also a little bit more easy to adopt when you're answering to the publicly funded system. So the cranberry extracts, which of course UTIVA does have one, how do they work? So Dr. Imlah did touch on the adhesion theory. So it used to be thought that it was more about the pH of the urine, or that we're creating an unhospitable environment for the bacteria to grow. But what the research has been showing in the recent years is that these packs, the membranes of, or the cranberries, they have an anti-adhesion effect on specifically the E. coli, from adhering and growing. So when I explain this, and also D-mannose works in a similar manner, is that instead of creating this environment that E. coli cannot grow, instead it's kind of coating the E. coli molecule, so then it's kind of like a slip and slide. Because if it gets the chance to adhere to the epithelial lining of our bladder or urethra, then it has a chance to root and grow from there. So with the packs, you can use them. There are studies to use as first line, of course, like with that child case, that was something that the child was otherwise okay. Kids can either get really good or they can go south, which is why I'll give a delayed prescription of an antibiotic. But they can also use for prevention. So things like the UTIVA and other cranberry extracts can be taken daily. And then you can also double or triple dose with trigger associated, be it intercourse or activities, or for people knowing that they're going to Mexico and they're going to be drinking and eating differently and being in bathing suits, you can increase to allow for increased coding of potential exposures. What I found really interesting in looking into the packs is that there's a lot of really great cranberry studies for preventing UTIs. There is one further down about first-line treatment, but you can read all these studies later because we want to make sure there's time for questions. But which one was I going to? The one I liked was this long-term case study. So anyone that works within primary care are going to have, of elderly patients or people that are institutionalized within long-term care, and they're all polypharmacy. But what was really interesting about these studies is the benefit of implementing cranberry extracts into this population for preventing and treating of UTIs, whether it's even through, I believe this study here, sorry, I'm jumping around. Was it the catheter one? Yes. So cranberry extracts I use commonly as a treatment, but also as a preventative. As I said, that there is acceptance through the Canadian Urology Association, Family Physician Guidelines, and Society of Obstetricians and Gynecologists of Canada. There's other studies here that you can look through. And I went a little hard with adding a whole bunch of how they're working. So bacterial adhesion, bacterial growth, biofilm formation, that's a whole other topic. Vaginal epithelial cells, inhibiting the growth. And again, a lot about the adhesion theory of UTIs. Another common one I use in my practice is D-mannose. It works similarly to the proanthocyanins by binding these type 1 fimbriae, so the E. coli cannot adhere and grow within the urethra and the bladder. And I know we're going to be asked why one versus the other. They do work together. I know there's studies from urologists that advise spacing them out. As I mentioned with the PED case, there is a product that one company makes that's a chewable. So that's nice to have for kiddos who can't swallow pills. Mannose also commonly comes as a powder, so it can be mixed into water, doesn't affect the taste. So with the pediatric population or anyone of any age, honestly, it's an easy compliance to get in. From the one product that's chewable too, for women that have chronic and recurrent UTIs, it's easy to keep in a purse where if you're out traveling or out hiking, that's a common one for women that don't want to maybe urinate on the side of a trail and they've dehydrated themselves, but they can start chewing to have that mannose and the cranberry extracts coat the E. coli and prevent the adhesion and the growth of the E. coli affecting a urinary tract infection. So there's a few studies here. The PubMed IDs are at the bottom. Majority of the studies were more with non-menopausal women for uncomplicated E. coli urinary tract infections. One study contained also some astragalus, which is a medicinal herb for immune support, and dandelion, which is a diuretic. So having to just help flush through the E. coli through the bladder. It also shows to be protective for recurrent urinary tract infections versus placebo, possibly with a similar effectiveness of antibiotics, and that it could be an alternative. There's also some studies that say that there's one meta-analysis that had no difference, but for what I've seen in clinical practice, it is effective. And also one of those agents that we can have if maybe that there's been recurrent antibiotic use and we want to switch up, but also while we want to promote the vaginal flora and our microbiome, which takes me to our third commonly used is probiotics. As Dr. Imlah has discussed, when prescribing antibiotics, we're affecting the microbiome. And I tend to tell patients it's kind of like our army. Like we all have staph on our skin, but we don't have flesh-eating disease. We have this balance of microbes all over our body, and we're learning more about it as each day and year goes by. But the more good guys we can put in our body, going to outcompete the bad guys, whether it's for UTIs or traveler's diarrhea. But with the people with recurrent and chronic UTIs, especially for the women that have been on nitro or macrobid regularly for years or using it for trigger associated, if we could do things to increase the microbiome of the urogenital area, we can see studies that show reduction in UTIs. But what I really wanted to get here was I found this interesting. So we touched on fosfomycin earlier with Dr. Imlah. I was trying to find studies that compared the natural extract to antibiotic use. There's some out there, some are poorly designed, some are older, but this study was designed to determine the effect of cranberry extract used in patients with single urinary tract infections, so not the long-term care or the chronic. So the methods of this were patients with a simple UTI were divided into two groups. One was given fosfomycin, the other group was given cranberry tablets. And then on days 1, 3, and 7 of the treatment, they were evaluated for their overall wellness, complaints of symptoms, etc. And as Dr. Imlah stated, that fosfomycin is a great single use. So for young women that in our conversations building this presentation for where she used to work at one point, people were on vacation. So people do not want to be on a 5-day course of antibiotic and give up their ability to drink alcohol or have to remember to take a pill. So fosfomycin is a good option, but also it does stay within the bladder for those few days. Where the other side of the arm of the study was cranberry extracts daily. I don't know which cranberry extract it was, but the result was that the leukocyte levels of the cranberry users were the same levels of the other group, the fosfomycin group. But what was different was on days 3 and 7, the cranberry group reported significantly higher well-being compared to the fosfomycin group. So this is a study that, like I said, there's not as many for first-line treatment using cranberry extracts compared to an antibiotic, but there's starting to be more. A lot of the studies are geared towards prevention of chronic UTIs and reoccurrence. But this is showing that perhaps you can initiate with a cranberry extract and or mannose and or probiotic, and given like your clinical consideration and judgment, of course, delay use of an antibiotic if needed. This slide I put in for, mostly I'm excited about these guys. So the UTI test strips that Utiva has. There's their products, which Mary I know can speak to you later about. But what's been great about the UTI test strips, as many Canadians know, access to primary care can be difficult at times. So we have patients purchase these, and if they do a home test and they have positive leukocytes, we have a consult and go from there. With the cranberry extracts as well, again, from getting access to primary care, we spoke about how if a patient presents to a pharmacy, say it's like a Thursday night, 8 p.m., UTI symptoms, can't get into their primary care, don't want to go sit in urgent care or the emerge for this. If it's not in a province or an area where the pharmacists are now prescribing antibiotics to treat UTIs, there are options to initiate a proanthocydin, a mannose, a probiotic to start helping the individual that has this UTI, or if you are a pharmacist in that situation that has the ability to prescribe, you can perhaps give it the prescription, but also allow them to start taking another treatment option before an antibiotic. Of course, clinical judgment. I always tell patients there's a time and a place for these things, that if patients come to my office and they have, really aggressive UTI, I'm not going to start with an proanthocydin. I will start with antibiotic and a probiotic, and then we just kind of clean up the stuff after there and look at preventing reoccurrence.
So we have a list of the references that we used, and as well then we have time for questions.
Jody was concerned we wouldn't have time for questions, and I said there's a lot of content in the slide, but also for the participants, you'll get the slide deck. We're happy to share that. You'll have a recording and you can look over the information, but also we wanted to make sure that there's going to be questions, a good question period, because we knew there would be a few.
Yeah, for sure. Thank you so much, by the way, for that presentation. I mean, I live and breathe UTIs all day by working at Utiva, and I learned a lot as well. So, I really appreciated the collaboration. So thank you for that.
Thank you.
Yeah, so we have a good amount of time for questions. We have tons of questions. So I'll just get into it, and then you can decide how you'd like to answer between the two of you.
Right.
So a little bit of a case study question here. How would you treat an elderly patient with recurrent UTIs, mainly bedridden, sometimes goes to the washroom and sometimes uses a bedpan, has had E. coli mainly, and used so many antibiotics that she's developed resistance and has one antibiotic left? We're using D-mannose, cranberry extract in high doses, and repeating probiotics as much via supplementation. What would you do?
So I'd ask one, what type of cranberry extract? Because in doing the research for this presentation, of course, we are being paid an honorarium by ZEO for talking about like proanthocydins and Utiva, but it was interesting in the data comparison about how as naturopathic doctors, we have a lot of cranberry extract and mannose capsules and urinary formulas at our disposal, but the saturation of amount of proanthocydins that get into the urine are not all equal. So if it's maybe one of a lower quality or a lower quality dose, the proanthocydins, same thing with the mannose. Perhaps this individual, depending on testing, so if we have a culture and screen, we know that they're still actually, if it's an elderly individual, they're still actually getting active UTIs versus perhaps interstitial cystitis. If we're talking interstitial cystitis, then there's a lot of botanical medicines and herbs that we can use as NDs that are demulcent. So it's kind of like a polysporin to the inside to decrease that irritation. But also I'm answering kind of generally, because if this is an elderly person that is under care, depending on creatinine clearance as well as their pharmaceuticals on board. Just because it's natural doesn't mean it's safe. There are some herbs that we'd use in addition for treating UTIs. There's like Uva ursi, the golden seals, etc., but they can affect, or some of them will interact with medications that are through cytochrome P450 or other detox mechanisms of medications that can affect their concentration. So I didn't really answer it, but I gave you options, hopefully.
Yeah, and I think that's the best you could do, right? Without having that patient in front of you. So thank you. This came up quite a few times. Why is Septra not recommended for treatment?
That's a pretty easy one for me to answer. So much resistance. So over 45% of E. coli's are resistant to antibiotics. So Septra kind of was our go-to for quite a while. We sort of moved from Cipro to Septra. Now we're moving on to other ones. I think we went to it a lot because it was a 3-day course, and so it was easy. But we know now that we just, with the high resistance, it is not recommended. If you know your local resistance pattern and you know that it's sensitive to the E. coli the patient has, sure, go for it. But just make sure you have a culture and you know that it's not resistant.
Okay. So I guess this is a good question. What dose of cranberry and for how long during infection and prophylactically? I guess maybe I don't know if you mentioned the amount of milligrams of the packs. You said high dose concentrations, but maybe you wanted to specify.
Well, if it's the Utiva, I believe it's, pulled that thing. So UTI control.
I think it's 36 milligrams.
Yeah, it's
Yeah,
36
Utiva's
milligrams per
36.
packs. And then there's other like professional supplements that are like a cranberry extract of 500 milligrams. So again, it depends on the person, the presentation. So if this was, say, the 22-year-old female, sexually active, and if she was declining or deferring the fosfomycin, I would likely give her 2 capsules and then have her repeat another capsule a few hours later and start taking the mannose and lots of fluids. And then if there is still irritation, advise her that she should take the fosfomycin. But for the chronic recurrent UTIs, for the Utiva product is the 36 milligrams of packs, 1 a day, and then 2 capsules around triggers. Or if women are having any symptoms, I'll say if you've been taking 1 a day, then when you start feeling symptoms, take another 2. And if they're just using the cranberry extracts, that's when I'll start using more of the mannose.
Okay. Okay, yeah, that makes sense. So basically, if they're more symptomatic, you're going to increase the dose, even throw in some D-mannose if necessary, and then for prevention, you'll do like a 1 a day.
Yeah, if it's symptomatic, obviously, then there's more E. coli causing irritation. Send in more proanthocyanins and or D-mannose to cope more E. coli.
Okay.
And dosing for children, it's not really like, it depends on the child for kid dosing and then the product.
Okay.
But it's
Great.
not always just so much the dose, but also the frequency. Like in the beginning, we want to just hit them a bit more frequent to just saturate the bladder and get it in.
Okay. That makes sense. And then moving on to D-mannose, another question is, and it does come up often, does D-mannose, because it's like a naturally occurring sugar, does it increase the sugar in the blood? Is this something that patients should be concerned about?
I get that question. So I have type 1 diabetic patients. And of course, with diabetic patients, they are, I believe, more at risk for UTIs at times based if their sugars are not well managed in the urination. I don't see it change sugars. Essentially, it's kind of coming into the bladder to coat the E. coli.
It's not absorbed. So that's why if they take too much, they get diarrhea.
Mhm.
So it'll draw water from into the intestine to attach to it. If you put too much in, people will get diarrhea. So it's classically not absorbed into the system. So it should not spike somebody's sugar. The infection will spike somebody's sugar, not the D-mannose.
Ah, okay. Oh, that's okay. So that's good to know. Okay, I'm just looking through all these questions. There's a ton. I'm trying to find something that might be, helpful for a wide variety of people here. I'll move on to like a bit of a case question here. See if
Oh,
you
Jody,
could
may I
help.
interject for a second? I just thought of something.
Of course.
The question that came about the elderly person and the recurrent and the resistance, we were speaking about this earlier too, is that we commonly talk about agents against E. coli, but then there's the other microbes that can cause UTIs with Klebsiella. So just for the individual that asked that question, if they don't have a culture and screen current, that would be a good one to get, because then that'll give you a bit more of a directive as to what's the offended pathogen and then how to treat that with either integrative natural prescription. I know that individual only has 1 antibiotic they're down to, but that's where you can start looking into more of the mechanism of action of other natural antibiotics.
And think about fungal and other,
Yeah.
right? Because that person is laying bedridden, very moist,
More moisture.
perineal area. It could be somewhat fungal as well, and no amount of antibiotics are going to fix that.
Hmm.
Yeah, there is actually an interesting lecture on chronic UTIs and with mycotoxins and with more of a fungal cause.
And what you'll see there is in their UA, you'll see more inflammatory cells. So if you see a lot of inflammatory cells, then you have to think about that you're missing, it may not be bacteria, it may be another causative agent.
Okay. Are you prescribing treatment with antibiotics? I think, right, yeah, with antibiotics before doing a CNS, or is a CNS the practice of care before starting the antibiotic?
No, if somebody has a classic UTI, they fit all the parameters. There is no worry or concern that it's an early pyelo and they're not somebody who's had a lot of antibiotics, then no, I do not do a UA. But if it is their very first UTI, then I do. And I will give them the antibiotics, but I'll get them to give us the UA. And then when they come back to see me and I see that everything is cleared up, I actually get them to take a picture if their UA shows any resistance, so that when they travel and do other things, they then clearly have the pattern of what they typically grow. But usually if it's their first UTI, you just want to make sure there's not something else going on that you're missing. But if they've had them before, they recognize it as the same, then I'm okay just treating.
Okay. So there was a question here about test strips. So if the UTI test strips come out positive on leukocytes, but negative on nitrites, should we still prescribe antibiotics? Question mark, maybe another bacteria causing UTI like Klebsiella or Proteus. What are your thoughts on that?
Well, we discussed that if there's the like Klebsiella, then the nitrates will show, correct?
They can be,
Yeah.
yeah, they can. But I think the key is that those screens, those test strips are so that people know, should I go and sit and see my, like, if you have to go into an urgent care, I don't know what it's like where everybody is. Here, it can be that you stay all day and you don't get seen and you have to go home and come back the next day. If you've got a positive strip, then you know that you need to find care. If you don't have a family physician or somebody you can phone, if it's negative, then you're like, okay, what else is going on? So it's just a way for people to be able to utilize it, to know, is this another bladder infection starting? Oh, it's very faint. Maybe I should start on my cranberry and other things and then see about, I can wait till tomorrow and see how it goes.
But also to that, like with any test, it's to give information to change potential treatment outcome. So if we're just prescribing just based on a positive leuk on a test strip, it's not appropriate because there's a lot of postmenopausal women that will naturally just have leuks in their UAs.
Mhm.
Or depending how patients collected the sample. Like there was one yesterday I had that it was skin flora in the sample, and the woman was postmenopausal and concerned about that, but it was when she collected the sample, she was not told about spreading her labia, midstream collection, etc. for that. So I think with any testing, it's information to help guide, but ultimately like patient symptoms need to be considered.
Yeah, that's a great point. Okay, next question here. I have a female patient, and I think it's a great question because it'll just kind of maybe re-emphasize what you've been explaining throughout your presentation. I have a female patient, 46 years of age, with regular menses. She is married for many years, and in the past several years experiences UTI after intercourse. She has been on multiple courses of antibiotics and is now on macrobid prophylactically. She has tried cranberry and D-mannose and probiotics, however, it has not been effective for her. I'm wondering if you have any insight, what dose and frequency of D-mannose and cranberry extract prophylactic and pre-post sexual activity would you recommend? And would you recommend that she stops the macrobid prophylactically as well? Like, what would you recommend here?
This would be a study I wish somebody would do, is take that group of people who are on 50 milligrams of macrobid daily versus, doing a protocol on Pax and D-mannose. So I'll leave it to Dr. Pratt to say what she would do, but long-term antibiotics, sometimes it's necessary, but maybe there's a way we can add in other stuff so that when she is active specific, we can decrease the chance of having to have a breakthrough UTI.
Yeah, I've actually had a few patients like this. So again, the macrobid being on board. So usually I'll start if the patient's already been on various cranberry extracts and manos, checking to see which ones they've been, perhaps doing a trial of something that's a bit more potent, whether it's Utiva or otherwise, and kind of layering those in. It's also about hormonal health. Like she's 46, she's perimenopausal. There's going to start to be some hormonal shifts. So what kind of like spermicides, lubricants, sexual practices are happening, because that can definitely affect the microflora. Also, the just around the time of the cycle, there's some women I treat that they're more prone in the kind of like week before their period, and perhaps like increasing up on these things. But this is also a good one to consider interstitial cystitis, also to consider fungal origin of the infection. And I'm thinking of like a few patients right now that this was actually how they discovered that their partner was having an affair, was that everything was fine for decades, and then they started getting more infections.
So I think it's a really good question. And so the other question back would be, they're having regular cycles, but that doesn't mean their vaginal health is what it needs to be. And when somebody's been with the same partner, they don't think about it. Sex might not be as regular, might not be as comfortable, but they just start using some gel or something else to help. It's a great person to start with some type of estriol is what I tend to use, suppository or cream or gel. I'm just not as keen on the gel because I feel like it doesn't moisturize as much as the creams do, but that would be a great addition to that and might make the difference.
Okay, thank you. I'm going to move on to I guess our last question, just because so we're considerate of time. It's a question on probiotics. There's been a few of them, so it'd be nice to kind of, yeah, cover that for our last question. So the questions typically with the probiotics have been, which strains do you recommend? And are the probiotics dependent on the type of antibiotic that was being used, or the type of infection that you're trying to treat? Like which, is it E. coli or is it Klebsiella?
Yeah, no, I understand the question, and it's really for probiotics, we're still learning a lot, but generally, if it's an antibiotic or a UTI that I'm prescribing, I'll prescribe at least 50 billion of a mixed lacto and bifidobacteria. Again, not just about the acidophilus for vaginal health, but to have the bifido for the colon health and then the lactobacillus for the small intestinal health. If it's outside of like a UTI, if it's more of GI issues, we use a lot more Saccharomyces boulardii for the spore probiotic for risk of C. difficile. With probiotics, I know at the health food store they'll be told to take them on empty stomach, but there's one researcher that spent his entire career as a microbiologist researching that it is take them with food because the pH of the stomach rises, so then more survive. And I'll usually dose them at least 2 hours away from an antibiotic, but I'll tell patients to take them in the evening, because it just, in my mind, I feel like, then they get a chance through the system to kind of go and start reproducing. Also with probiotics, I counsel a lot of patients that they're live organisms, that we don't need to take them all the time, that some people have been on the same ones for too long, too often, and it's now seen some of their gastrointestinal issues from it, that they're live organisms, that they self-replicate. If you eat a healthy diet, you don't necessarily need a prebiotic because that's what's going to fuel them to grow. But in the realm of talking about UTIs and of using antibiotic use, typically I try to aim between 25 and 50 billion CFUs and mixed lacto and bifido. There is also like various vaginal probiotics, etc., that are coming out, but there are studies that find the oral probiotics are still making it to the rectum and the vaginal flora.
Okay. And somebody just asked this question. I'll just add in, they asked when is the best time to take the probiotics for the stomach, and you had mentioned to separate like 2 hours after antibiotics, right?
Yeah, because the antibiotic will kill off a probiotic. And I know there's prescribers out there that say don't even bother till you're done your course of antibiotics. But again, it's just about competition. The more good probiotics you're putting in, you're just reducing the risk of that change in the microflora. And with food, just for the
With food.
ability of more of the spores to survive because of raising the stomach's pH, but also having, if you're eating good healthy food, you're getting that prebiotic to also help start them grow.
So I think it's really a case of what course of antibiotic are you having? and what is the easiest time to take it. So if you're twice a day dosing, take your probiotic with lunch. If you're 3 times a day dosing, probably mid-afternoon is the longer period between lunch and, or if you
Or
don't
before
eat breakfast, then take it in the morning, right? Like, oh, just the minimum is 2 hours away.
Okay. Okay, great. So anything you want to share, like last thoughts before we let you go?
Well, I hope that the participants of this talk gained insight into kind of both of our worlds and how we'll integrate them, but also for because we were asking questions about demographics, about the BC pharmacists being new prescribers, that having the ability to prescribe, but also having the ability of things that you also have OTC in your pharmacies to help support those people that are coming in after clinic hours. But also for other prescribers that are working in primary care, that we have our habits of what we like to prescribe, again, using your clinical judgment, but understanding there's a lot of data that perhaps we can delay use of antibiotics, just like we do with ear infections now and Advil.
Okay, great. Well, I wanted to thank you on behalf of UTIVA, and I'm sure everybody who joined this evening. Thank you so much for your time, for your knowledge, and yeah, just being here with us this evening. Really appreciate it.
Thank you, Jody.
Thank you. Bye-bye.
Bye. Have a good night.
You too.